Okay, perfect. So thanks everyone for joining us for the second workshop period. We're really excited. I'm going to introduce our speaker for today. So we have Professor Benjamin Perrin. Ben is a criminal law professor at University of British Columbia, the Peter A. Allard School of Law. He has served as a law clerk at the Supreme Court of Canada and was the lead justice and public safety advisor to Prime Minister Stephen Harper from 2012 to 2013. His latest book, Overdose, Heartbreak, and Hope in Canada's Opioid Crisis, which I've also read, great book, is based on the behind the scenes interviews and scholarly research chronicling his change of heart and mind to support a compassionate, evidence-based drug policy. The book is a national bestseller and was a finalist for several awards. Recently was a finalist for the Best Science Writing in Canada, the Lane Anderson Award, which is really exciting. And it's also been the Best Literary Nonfiction Award. And Ben's talk will focus on the urgent need to decriminalize people who use drugs in Canada. So we're really excited to have him with us today. And Ben, you can take it away.
Yeah, thank you so much, Maddie. And it's so exciting to hear that you read the book and, the kind of impact that it's been having. And yeah, I'm just thrilled to be here. So I want to start with just a brief acknowledgement of the land that I'm on here in Vancouver. I live on the unceded ancestral and traditional territory of the Musqueam, Squamish, and Tsleil-Waututh people. And the other thing I wanted to do is just briefly give a bit of a content note about our workshop today. As you would no doubt have expected, we will be talking about substance use and childhood trauma, incarceration, and also overdose deaths. There's some brief reference to the residential school system as well. And so obviously these can be difficult subjects and triggering and such. So we just want to make sure you do what you need to do to be safe. And a reminder too that we are recording this. So feel free if you need to take a pause or take a break, that's fine. You'll be able to view the session later if you'd like to and take your time going through the material. I also want to begin by acknowledging that there are undoubtedly people here in attendance who have lost loved ones and friends. This is not an academic topic. This is very much a real time where there's a lot of people who are still grieving and who have a very wide range of feelings and thoughts and views on this. So I just wanted to acknowledge that. And I also want to acknowledge that there are people here who have lived experience with using substances and or in recovery. And yeah, I never used the drugs that we're going to be talking about today, but I would describe myself as someone during law school in particular, and as a lawyer who misused alcohol and other substances too. And I'm very open with my students about that. I think part of what we're going to be doing through workshops like this, and hopefully your symposium, is we starting to destigmatize substances and people who use them. And I understand why I did that, and I understand that was a way to cope, and it was a way to kind of survive and get through. And that's why many people turn to substances. It's not just a leisure activity on a weekend, right? So I just want to acknowledge that. And in terms of support, I'm just going to post this in the chat, but this is a set of some just mental health and counseling resources that we compiled for some interviews that we do with folks with lived experience, and it's helpful for anyone. So feel free to access that, and I know the organizers are going to take a peek at that too. So if you feel like you need support, please do check in with that resources. So with those kind of important and announcements out of the way, what I want to cover today is, first of all, I'm going to punt it back over to you. We're going to do a bit of a warm-up quiz and see if you've read the book like Maddie has, then I'm expecting you to do really well in the quiz. So this is if you say you've read it, we're gonna find out how closely you read it. So, and if you haven't, that's okay too. We'll see kind of where your knowledge level is at, and you'll have a chance to put a question or two that you may have for the session too. It's gonna be a very quick quiz, so you're just gonna have a minute or so. You're not allowed to cheat. No Googling the answer. Okay, it's not for marks, but it'll help us, I think, get into the material for today. We're going to be framing today's discussion as what I describe as Canada's other public health crisis. And it's the one that has been predated the COVID-19 pandemic. It has continued today as well, and we'll get into some detail on that. I'm also going to show you a brief video from the First Nations Health Authority here in British Columbia of a family. I think you can't have conversations about this without in some way including people who have been affected by this. And my book heavily involved interviews with people with lived experience. And so I just want to make sure that it's in some small way are able to do that. And then this sort of latter part of the session is going to be focusing on the issue of criminalization and what are the consequences of criminalizing people who use drugs, and what are some of the recommendations that came out of the research that we did. And we'll have time for probably a very brief, but we will have some time hopefully at the end for questions. All right, so let's get started. Here's your assignment for today. You're not getting off easy. I know it's a Saturday, but some of you have probably used this website. You don't need to create an account or anything. Just go to socreative.com, so www.socreative.com, and then you'll go into login. And Maddie, if you don't mind, just post that in the chat. Maybe people can just click on the link. Then you're going to click on login and then student login. It'll ask you for a room number, and this is our room number. It's my last name, so Perrin, Perrin 4877. And once you start that, the quiz will begin, and I'll be able to track in real time how people have progressed through it. And so we'll come back once the most people have finished. So again, this is meant to be a quick exercise. If you don't know, guess, and I'll see you in a few minutes. And if you have any questions, feel free to just post them in the chat if you're having any kind of technical issues. I'm going to give you one more minute. So if you haven't quite finished, time to start wrapping up. All right, if you still have a question or two, that's okay. Feel free to finish up. Let's see how everyone did. So the first question was, how many people have died of overdose deaths in Canada between 2016 and September of 2021? Yeah, the answer was 27,000 people. Most of you got that. Second question, during the COVID-19 pandemic, the number of illicit drug overdose deaths has decreased. True or false? Yeah, the answer is false. They have actually increased, I will say exponentially, but that's a bit of a hyperbole. I'm going to give you some actual figures, and you'll see in some provinces, like where I am in British Columbia, the comparable rates actually between COVID-19 deaths and illicit overdose deaths during the first 6 months of the pandemic. I think that will surprise maybe even some of you who got the correct answer here. It certainly surprised surprised me, but it was, totally predictable. What percentage of all accidental apparent opioid toxicity deaths in the first little chunk of 2021 involve fentanyl? Yeah, so the right answer is 86%. It's an incredibly high number. And something that I mentioned in the explanation you would have seen is that this isn't, only about fentanyl, but there is a significant issue with what's referred to as polysubstance use. And so when you look at the death panel reviews done by coroner services, I know there's a lot of people who've got training in pharmacy and such. What you see is a combination of different drugs, and it's the combination that we're told it increases the risk as well. So in particular, benzodiazepines mixed with fentanyl, alcohol mixed with fentanyl, these combinations of drugs. It's one of the reasons why, harm reduction education for people who use drugs includes not to mix substances, right? Not to use alone, not to mix substances. Start low and go slow. Hopefully you're familiar with some of these things. Not use alone, have naloxone. These are things that are, routinely understood now to help reduce harm and save lives. I love trick questions. I don't ask them in real life. Okay, just so you know, on exams, you can ask my students. I don't do that, but I had to sneak one in today. What country is fentanyl poppy grown in? Oh, I tricked so many of you. So many, only 9% of you got the right answer. There's no such thing as fentanyl poppy. I didn't know how you'd answer. I'm thrilled I tricked quite a few people. Yeah, I mean, Colombia is known for its cocaine production, Afghanistan for global heroin production. China is where the majority of synthetic fentanyl is synthetic, where synthetic fentanyl has been imported to Canada. Certainly not all of the above, right? So the vast majority of the audience, they didn't get that right. Now, the reason why this is significant, that fentanyl is a synthetic opioid, is myriad. So let me just get into that a little bit now. So fentanyl was created in a lab in the late 1950s in Belgium for palliative care. It was created to alleviate pain of people who are dying of cancer and other debilitating diseases. And so that's the starting point. So think about that for a second. So the drug that people are using in massive numbers and quantities in Canada is meant to relieve pain. Okay, that's the starting point for the conversation. We're going to get into trauma in a minute here. Okay, this is a pain relief drug. I didn't know anything about what fentanyl was before I started this research. I assumed it was like kind of like a party drug. People were enjoying it. There's no stimulant effect. What happens with fentanyl is people get very tired, and if they have a uncertain quantity and they're not being properly monitored, they are at risk of going unconscious and then stopping and breathing and dying. Now, I have had fentanyl, not from street drugs, from a medical procedure. Now, there are two things that kept me safe and why fentanyl is widely used for both humans and animals since at least the 1970s and probably even a little bit earlier. The two things that made it safe for me and my son, who also had an emergency surgery at one point and was given fentanyl, because I asked, I was curious, right, doing this work, what did you give me? And fentanyl, okay, all right, here we go. Let's see what this is like. Is number one, it was known potency, right? So as a group of medically trained or people being medically trained, you understand what that means, right? Carefully titrated amounts. You can know exactly what I'm receiving. It's calculated based on my weight and my gender and all these other factors that I don't even know about. You could tell me, right? So it's controlled. The second thing is it's monitored, right? So when I was undergoing a procedure, there was one person whose one job, like you have one job, was to monitor my vital signs, my breathing rate, and able to, when I started to actually kind of come out of the procedure, they gave me a little bit more, no doubt. And to ensure I did not slow my breathing and stop breathing, and then be at risk, obviously, of death, they are able to, in ways that you could expand on better than I, manage that, right? And so both of those things, when either or both of those two conditions are absent, we have a significant risk of overdose death. And so the first one is that we have a toxic, contaminated street drug supply. There are people who use substances who now seek fentanyl because they know what it is and they've used it and become, I'll use the word dependent on it. I don't like that word, but I think everyone knows what I mean when I say that. And and will intentionally choose it. Even then, though, they don't know the quantity of it. So we're talking about grains of sand. The potency of fentanyl that can lead to an overdose death, you're talking about literally grains of sand-sized pieces of it. It's essentially in a crystal format. And when we spoke with undercover police officers who do buys of street drugs and test them, and who go and raid so-called drug labs, they found fentanyl being mixed not in the carefully titrated way like in the medical setting, but in like literally blenders mixed in with buffers like caffeine and put into pill form. Okay, so that first condition of known contents and potency is completely and fatally out the window. And fentanyl has been found contaminating every street drug that you can imagine. So people who are going to buy ecstasy pill, could be fentanyl in it. It's frequently found in there. Okay, cocaine, fentanyl, meth, fentanyl, you name it. Okay, and so it is incredibly cheap to produce. You can literally produce it. The people who are attending this event, you already have the chemistry knowledge from your introductory chemistry course to create fentanyl. I verified that with the National Security Lab in the United States. The way I did this was part of the fun of this research. I spent 5 minutes Googling as a law professor. Okay, I haven't taken a science course since high school, for a fentanyl recipe. That's what I literally was looking for. And I did a couple of quick cross references, and it seemed legit. And so I contacted a scientist at this National Security Lab in the States who had written a paper on homegrown fentanyl that I also found in my research. And I said, can you just verify for me that this recipe would produce fentanyl? And he said 100% yes. And I said, what about the precursors and all that? He said you could all get all of it legally and all of it with basic equipment. He said college, maybe if you had a good high school chemistry teacher, you could pull it off. Okay, so this then bleeds into issues around cracking down on supply and all that. You could read the book on that and learn about something called the iron law of prohibition. I can't tell everything that's in the book in this talk. Too many spoiler alerts, and I don't have time. But basically, the attempt to crack down on heroin globally led to, and as you'll see in a minute, a chart showing this in BC at least, a massive upsurge in replacement of fentanyl. So even if we got really good at seizing it at the border, which is a needle in a haystack exercise, it can readily be produced in Canada, like methamphetamine could and is. All right, the second piece I mentioned about fentanyl and why it's so deadly is that when someone is either using alone or they're using with someone who's not able to provide them with the quantity of the drug, which is a temporary antidote to reverse the overdose effects of fentanyl, that's naloxone or Narcan. If someone's not helping them with their breathing, if they're in a state of depressed breathing or not breathing at all, then they're at risk of I think the term is, I've got all these medical terms in my book from the experts I spoke to, but essentially, brain injury, like permanent brain injury, and if not that, death. And prior to COVID-19, we were told there were entire ICU units in BC that were full. And the reason they were full is because there was people who didn't die, so they're not included in the 27,000 people who've died, but they have had debilitating like brain injury. They're permanently disabled, right? Which is another part of the tragedy that we don't hear about. So people who use alone is one of the greatest risks. And why do people use alone? One of the main reasons is stigma around drug use. So I talked about that a little bit earlier. Another reason, it's illegal, right? It's illegal. It's a crime to use this drug. So when you see all the photos and images on websites or the news or Twitter, and if you haven't, go and look. There's a website called Moms Stop the Harm. Moms Stop the Harm. I talk about them in my book a lot and interviewed the person who founded that group. You're going to see images of folks that look just like you and me. Okay, it just knows no borders, and they're all considered criminals. Okay? Every single one of them. The law considers them to be criminals for their substance use disorder, right? And so that has a couple of effects. That means stigma, so don't tell anyone. Secondly, you could get charged and lose your job and lose your livelihood, lose your housing, okay? Even if you don't go to jail, right? The other aspect of that is if you're in a recovery program, for example, and it's an abstinence-based detox, which I'll talk more about in a second, program, then you're not going to feel safe to say, I actually feel like I might relapse. And if you do, you go in your room and use, and then you overdose and die. And there was a coroner's inquest in British Columbia of a recovery center where that exact thing happened. It was a young man, his family basically remortgaged their home to put him in this, top-notch, what they thought was a top-notch recovery center. He used a loan and died, and he had been released from prison. And he was under conditions, even with a substance use disorder, that he not use drugs. And so the criminal law system not only makes it illegal to possess drugs, but for the vast majority of people who get charges and have some substance use involvement at all, they are routinely told to abstain. And if they do use, they are in breach. Another thing that I document is they're told not to possess drug paraphernalia. We spend, I wouldn't even know the figure. I'm sure it's probably close to, nationally over this period of time, probably close to $1 billion. I'm just making a number up here, okay? But it's got to be a huge number on harm reduction supplies. Okay, clean syringes, naloxone kits, all that. Someone who has a no drug paraphernalia condition as part of their probation order or their parole order or other forms of release that you get from the criminal justice system is considered to be committing a criminal offense when they have a substance use disorder and have a clean syringe. So we are investing a massive amount of time, effort, and money in our public health system, and folks like yourselves trying to encourage people to do the right thing to protect their physical and mental health and well-being through harm reduction supplies. And on the other hand, the criminal justice system is spending the total for corrections in Canada is $5 billion to incarcerate people, 70% of whom have substance use disorders. So this is complete lunacy, right? And people are going to look back on how we are currently dealing with substance use in the society. I believe one day, very soon, and some already see it this way, just as absurd as it was to, the Inquisition or, things that we look back on, corporal punishment, dark Middle Ages type stuff in Europe, because it is so cruel, and there is absolutely no evidence behind how we're taking these steps. All right, so that was a lot, but only 9% of you got this right, so we had to spend a bit of time on that. That's okay. I'm really glad I tricked you. I'll keep that question for next time. Next up, list as many of the original 10 adverse childhood experiences as you know and can remember. I'm not sure how many of you even knew about the ACEs survey. I didn't know anything about it until I got into this research, and I've been working in the criminal law field in some way or another for 2 decades, which is shocking that it's not taught in any law school program that I'm familiar with. So yeah, we've got a range of things here: emotional, physical, sexual abuse. Yeah, absolutely. Yep, death of a parent, divorce and separation. Yeah, witnessing violence. That's right. Not even just being subject to it, witnessing it. That's right. Parents who have mental health conditions, parents who have, so you're the child, right? So that's your parent has a mental health disorder, your parent has a substance use issue. Incarceration, I don't see listed here, but that's one of the original 10 ACEs. And you'll have seen as well in the explanation for this slide. Oh, good, I have it here. There's the full list just for the screen. Subsequent research into ACEs has found other things, including racism, being bullied, feeling unsafe in your community, being in foster care, poverty, serious accidents and illness, parents who often argue, and having no close friends. So there's another maybe 10 or so there. So if you don't know about ACEs, I encourage you to, as part of your own kind of continuing learning, Google them. The US Centers for Disease Control and Prevention have a great summary of them, and they are connected to so much. They're considered the cause of causes. And there's a great book by Drs. Robert Maunder and Dr. Hunter called Damaged Childhood Trauma, Adult Illness, and the Need for a Healthcare Revolution. Everyone, in my view, who is in medical school needs to read this book, and we all would benefit from reading it. It just came out from the University of Toronto Press. So for your future reading plans this summer, get a copy of Overdose, and then this one for more of a direct health connection. Next up, people with an ACE score of 5 or 10, so 5 out of 10, so meaning half of the original 10 ACEs, were how many times more likely to have an illicit drug use problem than someone who had none of those? Yeah, okay, so almost there. Yeah, 7 to 10 times more likely. That is a massive order of magnitude difference. And the thing with adverse childhood experiences is they are not additive, but they're in the sense of 1 + 1 is 2, and you're only kind of twice as likely, they actually go to the 2 to 4-fold increase each ACE you add. So it's more of an exponential type of effect, an accumulative effect. There's a really interesting study, which I can share with anyone who's interested later and track it down for you, looking into residential school survivors and their children and their children's children. And the average residential school survivor, kind of in terms of the typical experience, experienced at least 6 ACEs, okay? Some of you may be familiar with the continuing and emerging research on epigenetics, but the idea that this is actually passed on genetically as well, that trauma is actually not just a product of our environment, but it actually is passed on genetically, meaning that if you, for example, were never even met your biological parents, you would still carry some of the trauma that they experienced, okay? This is incredible stuff, like very, very significant for both criminal justice and also for the treatment and recovery of people who have experienced childhood trauma. The next, people always ask you when you've written a book, what's the next book? I'm literally writing it right now. And so I'm really excited about it, to look at reimagining the criminal justice system as a whole. Overdose was about this particular issue, and it got me thinking about the whole system. And so the role of trauma in that book it plays a huge part. And I've learned even more about ACEs, so I just encourage you to keep learning too. Now, this one was, I would say, I've included in this quiz some of the biggest shockers for me that were part of this research. People with opioid use disorder who successfully complete a 28-day abstinence-based detox program are, can you believe that? Look at that. More likely to die from overdose than those who fail to complete the program. So what are the reasons for that? Well, the most straightforward reason for that is that people with opioid use disorder rapidly lose tolerance. We're talking within days and weeks, rapidly lose tolerance. And so given this is a chronic relapsing condition, if they're on a 28-day abstinence program, their initial tolerance has gone just down into the ground. And so when they do relapse, and there are people who do stay in long-term recovery, that's not what I'm talking about, but I'm talking about the studies of, which, as you know, look at cohorts of people. So on average, when they do relapse, they are significantly more likely to overdose. And this study, by the way, tracked them over a 1-year period, if you're curious. So it tracked them over a 1-year period after being in a 28-day detox program. One group finished it, one group didn't. So the people who, I'm putting this in air quotes, failed the treatment, okay? They didn't succeed, okay? They failed, that's how it's termed usually. They were unresponsive, non-cooperative. The criminal justice system would say, oh, they need to, treatment didn't work, so now they're going to jail. Well, they're actually more likely to overdose and die if they complete the program, okay? So that's why in the explanation note, you can look into this. These are all cited in Overdose in the notes at the end. The British Medical Journal study on that, it's been reproduced many, many, many times. And the BC Ministry of Health guidelines on clinical management of opioid use disorder do not recommend detox on its own as a treatment. It is not recommended. And you can see the words here. It also includes not just the elevated risk of overdose death, but communicable disease transmission in comparison to providing no treatment at all. Okay, so Hippocratic Oath stuff, right? You know this better than I do, okay? Do no harm. This is doing harm. This is actually making it worse. And I'll tell you, the criminal justice response is making it even worse as well, because while drugs are readily available in prison, they're not the same contents and potency, and they're not as available as on the street. And so what the BC Coroner Service Death Panel Review found when it looked at all overdose deaths in a 1.5-year or so period was that the most common characteristic of folks who died of overdose deaths were people who had recently been released from prison or corrections services. It was actually jails, this the provincial term for it. Okay, and so absolutely, the point that I didn't even come out as strongly as I think I could have in Overdose, that I will be in the next book. It just didn't occur to me, but it's clearly true. Incarcerating people with opioid use disorder is equivalent to giving many of them a death sentence. That's quite, and overdoses in prison are also significant. Some further research I've done found that people who are released from prison who have opioid use disorder have I believe it's 50 times more likely to overdose than someone who's in the general, sort of population or in prison. So this is serious stuff, and we've got to get educated on this and start changing how we deal with things. You'll often hear politicians, particularly conservative politicians in Ontario and Alberta, say we need more detox. Boy, oh boy, I would be coming back with these surveys. They need pushback on this stuff. So that is the biggest thing they can do. And it's about stigma again. It's just stop using, just go detox, go cold turkey. And you'll hear stories of people who did go through the debilitating effects of withdrawal, which if you're not familiar with, get familiar with, or in the book. They can include not only vomiting and nausea, but seizures. It can actually be fatal to just stop using drugs on its own, forgetting the whole relapse piece, right? So yeah, we see the stigma roots run deep in the dialogue around this topic. As more drugs are seized by the authorities, drug prices increase for people who use drugs. True or false? Gotcha again, false. This is the iron law of prohibition. Look, organized crime makes trillions of dollars in all likelihood by the global drug trade. So as literally hundreds of tons of heroin and cocaine get seized over the last 40 years or so, they don't just pack up their bag and go home. They dusted off this recipe. No one knows who started it, but they figured it out quickly for fentanyl, right? Created in this lab, dust it off, readily produce it. So what happens is you reduce bulk. So something that's more potent, imagine this is a kilogram of heroin, okay? To get the equivalent opioid hit, shall we say, for fentanyl, because it is up to 50 times more potent, it's equivalent to just smushing it down and sliding it under a door. And what we found from the Canada Border Services Agency, who checks the mail, and the checks is a loose term, coming into the Vancouver International Airport, where all of the mail from all of Asia comes to this one airport. There's millions and millions of packages a month. And they found, like, I forget the number off the top of my head, it's in the book, but it's like 50 or 60 packages they found. And we're talking greeting cards, okay? Because fentanyl is, again, grains of sand, you just put it in a little Ziploc bag, pop it in a greeting card from grandma, okay? So this is not getting slowed down. And so what happens is potency goes up and prices drop. So this is the paradox, right? It's a paradox. How many of us thought, hey, economics 101, if you limit supply, price goes up, right? Well, organized crime never took that class, and it doesn't work. It's had the opposite effect. So you can see all the unintended consequences, all the kind of bizarre outcomes. And this really helps explain why we're stuck in this bizarre world where up is down and down is up. And we need to unlearn what we thought we knew about substances and their treatment. Some questions here. Hopefully I've answered some of these. Looking at changes, need to be done. Obstacles, supporting someone with high ACE scores. How can pharmacists make a difference? What do we do to move towards decriminalization? What about other countries? Not sure yet. So we're going to cover off a bunch of that in the rest of the time that we have. All right, so I'm going to go ahead now and come back to the slides. So just bear with me for 1 second. And I tricked more of you than I thought, so I spent a lot of time going through that quiz. So I'm going to whip through these a little bit quicker. This is the sort of best available information provincially is kept by British Columbia. I think it's fair to say. I'm not trying to do a comparison game, but we've been hit the hardest over that time period. And so it's also where I did my research. So I'm going to focus on BC. But Ontario, where you're based, is also among the hardest hit provinces. So Alberta, BC, Saskatchewan, and Ontario are top of the list when it comes to continue to be at the top of the list. They together represent something like over 80% of opioid-related overdose deaths. So you can see the curve. You're down here in 1995. The light blue bars are the actual number of deaths, so the raw score, and then the rate, per capita rate, is the line, the dark blue line. So this is for all overdose drug deaths. So you can see it's in a relatively narrow band until about 2014, 15, it starts to take off. In the book, I talk about why. So I don't have time to get into that, but you can see this is described as the epidemic curve. We're all familiar with this from COVID. You see it started to take quite a precipitous drop in 2019. I haven't seen any really good research on why that happened. I think the speculation I've seen, there probably is research at this point, but was that's when you're likely seeing a combination of things. First of all, is that this is also through attrition, right? People who are using substances are a certain proportion of the population, a larger portion than people believed probably, but eventually, just because of the accumulation of loss of life, it eventually begins to have that. But we also do have data and research that shows that harm reduction approaches were rapidly scaled up during this period. In 2016 is when BC declared a public health emergency. Canada has never declared one for the overdose crisis, even though we see a similar curve nationally. And so you see some positive impacts of harm reduction on the opioid crisis. But then, of course, COVID-19 hits and we are back on a skyrocketing, is not an exaggeration. You can see that the rate of growth, and it's only continued. This just goes until first quarter of 2021. This is something which I use in discussions with folks. It was pivotal for me. I try to think about what were the big takeaways for me, that helped me understand why we need to do things differently. The childhood trauma thing was big. The law of unintended consequences was big. This was another one. In BC, more people continue to die of illicit drug overdoses than suicide, homicide, motor vehicle accidents, and prescription drug overdose combined. Okay, combined. It is the leading cause of unnatural death. Nationally, this is from 2020. Numbers have all gone up everywhere. You can see the darker the color. I try to explain graphics, by the way. If people just throw stuff at you, I always get cranky. So I'll just briefly, you can't read it all. So the darker the color, the higher per capita death rate. And the numbers that you see are the raw score, the actual number of people who died of illicit drug overdose death. And that's actually just between January and September of 2020. I mainly wanted this graphic for you to see that it is a national problem, but that it is heavily concentrated in, we'll say, largely Western Canada. This is the graph I mentioned before. The red, this is from 2020. So January is the first, February, March, all the way down to August. Okay, so when did the lockdowns all happen? Right here in March. Okay, COVID-19 lockdowns. So the overdose deaths are in red. The COVID-19 deaths are in blue. Okay, so I think the reason that people who are advocating in this area refer to these statistics, and in my book, it was obviously the pandemic hadn't happened yet. So I was comparing it to the SARS incidents in Canada earlier, but we have seen nothing in the order of, not even close, right, to the public response, the amount of time, effort, money, and public resources put into addressing COVID-19 than we do with the overdose deaths. And there are many reasons for that, but the top of the list is stigma. When we look at stigma, the word stigma, by the way, I found it really helpful to get out of thesaurus because we don't use that word often, right? Stigma basically means opprobrium. That's also not a word you hear often. Why? Because it is so strong. It refers to condemnation and blame and vitriol. Those are all synonyms for stigma. Okay, and so when the World Health Organization actually, I don't think it was them. There was an international study that I cited in my book about studies of stigma, and they asked people around the world, and they gave them a list of different people. And they said, who do you have the highest, stigma for? And the top of the list was people who use drugs. It was even higher than people with leprosy. And they asked people in countries that still had leprosy. So people would rather hang out with people who have leprosy than people who use drugs. Okay, this is stigma. So stigma has a number of sources. There's people who study it. One of them is what law says. Okay, that's one of the three main sources of stigma. Is what are the statements that your law makes? One of the purposes of criminal law is denunciation. That is one of its main expressive functions, is telling society what is right and what is wrong. And the message that we're sending through our criminal law is that all of the people who have passed away and those who continue to live with substance use disorders deserve our vitriol and condemnation. That's what the message is that we're sending. Okay, there is literally no other public health issue where we see that level of hatred. And it's incredibly disheartening. And one of the most important things that I've been able to do to break through that, because those are views that, I wouldn't say I hated people who use drugs, but I definitely looked down on them. I was definitely afraid of, walking by someone on the street who I saw, if they had a syringe beside them or something, I would cross the road. I don't do that anymore, right? And it's because I learned about, what brings people to those places. I heard from loved ones. And so that's what we're going to do next. This is a 5-minute video. It's from the BC First Nations Health Authority. And it's just describing in real terms, how the opioid crisis has affected one family in particular here. So give me one moment and I'll pull that up. Okay, can everyone see that okay? All right, great.
Brother was just taken from us. He had a big heart. We all loved him so much.
He was a pretty happy child. He was very curious. Julian loved all his friends and especially his girlfriend. He has 3 beautiful kids. He loved life, but he just couldn't get a hold of what he really needed to. I love him very much and I miss him a lot.
Opioids are starting to be an epidemic. We've been seeing an increase in the number of overdose events and overdose deaths for many, many years now. We see it as a health issue and not as a moral issue, in that everyone deserves help. No one deserves to die because of their addiction.
My wife is a first generation survivor. I'm a second generation. My son and daughters here, they're like third generation survivors. Each individual has to look at what happened to us. The residential school survivors, what they did or did not do to keep their young ones alive, and well, let them grow up, without the emotional, or sexual or physical violence. Yes, there were people dying 25 years ago. Our people were dying, but now there's fentanyl.
I'm often asked, why do people use? And I don't think that's the right question, because that sounds a bit like, what's wrong with you? It's more like, what happened? Why do you find yourself here? And most of the time you'll hear from people that they're using to try and feel better about something.
I hope the ones that are affected through second and third generations with the drugs and the alcohol, that they really seek the help they need, and that is through counseling.
There was a lot of counseling. And in that counseling, at first it dealt with the drugs and alcohol, but then after that, we got into the trauma part of what residential school did to us.
Try and hold their own families really close and talk to them a lot more and communicate with them. Try and think of other alternatives in their lives.
For me, it was like stepping back and looking at my son and holding him and saying, I love you, son. Whenever you want, we're here for you.
One of the first things that you want to say to someone you love who's using is to ask them, make them promise to not use alone. People who use alone can't be helped when they get into trouble.
To stay strong. Don't give up on yourself. You got your family that care about you. Your parents, your brothers and sisters, aunties and uncles. There's a much better life out there. Know that there's help out there. It's not too late.
There's a lot that we can do to help our loved ones who suffer from addiction. And I don't think there's a family out there that isn't affected by addiction, so let's all do that we can to save their lives.
I am really grateful for that, the family for sharing that. The more that you hear and learn about this crisis and the devastation that it's causing, I think it does something to our hearts. The kind of big theme of my book Overdose is that it's not just a head change that I went through and that I think others in our society needs to go through. It's a heart change. It's not going to be like another 20 or 30 or 40 peer-reviewed studies to say that supervised consumption sites or overdose prevention sites save lives. That's not going to convince people who are already decided in their own minds that those things are bad for whatever reason. There needs to be some sort of heart change. So let's move on now to talk about squarely on the issue of criminalizing people who use substances. So to begin with, there is absolutely no peer-reviewed evidence to suggest that our current approach to criminalizing people who use drugs is effective at reducing overdose deaths, or that it is effective at deterring people. Okay, so there is zero evidence for that. It doesn't exist. It can't be produced. So why do we have it? I get into that in the book. I look at the historical origins. It has absolutely nothing to do with public safety. Even at that, it has roots in racism, and particularly with the criminalization of opioids. It was one of a suite of racial discrimination and segregation laws in British Columbia to harass and intimidate and essentially force to leave Canada a significant portion of Chinese Canadian people. Basically, as soon as the National Railroad was finishing up in BC, there were laws that were almost passed immediately, including laws to try to criminalize opium, which when smoked was, we're not even talking about fentanyl, significantly reduced. And a study that was done at the time, even by a man who would become the Chief Justice of British Columbia, actually found that alcohol use in British Columbia was a bigger issue for public disorder than opium. And yet we know how that all played out, right? So here's a couple of sort of top level consequences that flow from criminalization. First of all, it directly has contributed to and exacerbated the opioid crisis. I talked before about the impact of the war on drugs. And I get into that in a lot more detail in the book with some interesting studies that have come out with specific, numbers and percentages of price increases and percentages of potency increases. And, fentanyl was considered the kind of big scary drug before. Well, then carfentanil came along. If you've seen Jurassic World, some of you probably watched again to see the new movie. I'm planning to go and see the new movie. They literally refer to using carfentanil to sedate the Tyrannosaurus Rex. It's used in veterinary medicine to sedate elephants. And it is found in urine samples of living people now, because of the tolerances have gotten up that people who are long-term opioid users have developed a tolerance to even carfentanil. Someone who's using drugs at a wedding reception, which are real cases that we have in the book, who's never used any opioids, has absolutely, their body has no chance of processing or even a grain or two of carfentanil. So we see that criminalization has fueled the toxic and contaminated street drug supply. It is easier for me, for my house right now, to go and purchase fentanyl laced street drugs. I live less than 10 minutes from the downtown east side in Vancouver. It's easier for me in 10 minutes to walk back here. I could even do it as the session's ending. That's how quick. It's easier to do that than it is for me to find unpasteurized milk. Okay. Why? Milk is regulated. Okay. Now I know there's probably some unpasteurized milk fans in the crowd. That's great. The point being, though, that milk is regulated, right? So having an unregulated supply has led to this. So that's why one of the solutions, or not solutions, one of the things that needs to happen is a safe supply, right? Secondly, criminal law is meant to punish morally blameworthy conduct. That's the overarching principle. And so when you punish someone for having a substance use disorder, you're saying that that's morally blameworthy, right? Well, we know, in fact, it's a medical condition. Some people try to go back and say, well, but it was a choice initially, like when the first used. But there's some research which even discounts that and says that there's a degree of initial use driven by things like childhood trauma, genetics, peer influence, and things that wouldn't make it so much of a sit down and say hey, should I go watch Netflix today or use some heroin? That's not the choice anyone ever made to use these substances. 3, I've talked a lot about this. It fuels stigma. 4, it endangers health and lives, encourages using alone. Other research shows that it encourages people to use quickly. People who are experiencing homelessness in particular with street patrols of police, even if they are using their discretion to not charge, which is the official policy in Vancouver and other cities now, not all, but many other cities, the police say, well, we have de facto criminalization, the crime, right? Well, no, what they do is if they see the drugs, first of all, the people in the street don't know and don't trust the police because of their prior interactions. They're going to use quickly, and that's against the best advice we have for folks. And if they are caught, the officers, we're told, typically will crush the drugs and mash them into the pavement. If you're dealing with someone who is involved in the sex trade to earn money or even just sex for drugs, that then is having that person have to go back out and go through that ordeal again. Okay, so or go to a different dealer who they don't know, and that elevates their risk, they say, okay, because they don't trust other folks. I talked about conditions of release already. Number 5, it's very isolating. So criminalization isolates people from support in myriad ways. First of all, the stigma, but also something called red zoning. Other conditions of release include you can't go in certain areas of the city, and that's often where harm reduction areas are located. Criminal records can have you booted out of housing, not able to get a job. Number 6, it fosters other dangerous and criminal behaviors, things to get the money you need to keep buying these monopoly priced, drugs, which have gone down in price, but they're still very expensive for someone who's on the street, obviously. I've talked about number 7 already, about incarceration, increasing overdose deaths in custody and post-custody. And number 8, criminalization raises barriers to rehabilitation. You're unable to qualify for many programs and services with either a recent release from prison, including mental health programs, by the way. So some of you are familiar with the sort of community treatment, which is the kind of high level of treatment and community for people with severe mental health conditions, disorders. And I've been told by a forensic psychiatrist at CAMH in Ontario that in Toronto, ACT teams were not allowing people who are on bail to even be admitted to their programs. So criminalization also prevents access to mental health resources. So at the end of the day, where does that leave us? Well, it's been a total disaster, which has made things worse and arguably been part of precipitating the opioid crisis. And so the bottom line is our drug laws and policies should be based on evidence and compassion towards people, not ignorance, fear, ideology, and stereotypes. So I'm going to stop there. In the book, I outlined kind of seven key recommendations that came out of the study. We had people with lived experience, survivors, addictions experts review those and gave us great feedback on them. And so I just want to give credit to all the folks who took the time to meet with me and shared their stories and expertise. So I'll stop there and pass it over to Maddie, and I think we have a few minutes for some questions. Thanks.
Awesome. Thank you so much. I will stop the recording now.